of HSCT Mexico. I'm Dr. Juan Carlos Olivares. I'm the transplant coordinator here at Clínica Ruiz. And today I'm here with Dr. Guillermo Ruiz Argüelles, who is head of the program. So today we will be talking about HSCT for MS. So HSCT Mexico and Clínica Ruiz is a company that was founded in 1920, and it is a medical compound that has several services, such as Laboratorio Ruiz, which is a clinical laboratory, also imaging and MRI, Farmacentro, which is a pharmacy that provides the medication required for the transplant, Hemapheresis de Puebla, which is the blood bank that conduct the apheresis and recollection of the stem cells, and Hematología en Medicina Interna, which is Hematology and Internal Medicine, which is the clinic where we are conducting the chemotherapy and the transplant. So all these facilities work together to provide care to our patients. So currently we are the largest patient volume autoimmune diseases HSCT private treatment center in the world. Professor Ruiz Argüelles and Professor Gomez Almaguer in Monterrey has performed more than 4,000 HSCT procedures during more than 20 years. And we provide a comprehensive care that helps patients to manage their symptoms and improve the quality of life. That is one of the main goals, to improve in multiple sclerosis and autoimmune diseases. So now, Dr. Guillermo, you can comment with this.
Thank you very much. Yes, I am Guillermo Ruiz Argüelles, and I started doing transplants in 1993 here in Puebla, initially for persons with hematological malignancies, and a long time we have been growing our program, and the number of persons that we have grafted here in this program is 4,071. Around half of them have been done in Monterrey, and half of them have been done in Puebla. So we have similar numbers in both centers. Next slide, please. The center in Monterrey is headed by Dr. David Gomez Almaguer, and the center in Puebla is headed by myself. Both Dr. Gomez Almaguer and myself were trained in internal medicine and later on in hematology. We have dealt for very many years with persons with hematological malignancies, and we have gained expertise in the last years in hematopoietic stem cell transplantation. As I said, initially in persons with hematological malignancies, and then later on we moved into the autoimmune area, where we have put together the largest single program experience in the world, having grafted around 1,800 persons with autoimmune conditions, most of them with multiple sclerosis. As you can see in a brief description of our biography, we are supported by two young physicians, two young hematologists, Dr. Guillermo Ruiz Delgado and Dr. Andrés Gómez de León. Dr. Guillermo Ruiz Delgado works here in Puebla, whereas Dr. Gómez de León works in Monterrey in the center headed by Professor Gomez Almaguer. Next slide, please. This is a timeline about our program, and also compared with some important facts in the history of bone marrow transplantation. As you can see, the first HSCT was done in the United States by Professor Donald Thomas, who later on was granted the Nobel Prize. The first transplant in Mexico was done by Dr. Gómez Leal in 1960, and the first HSCT was published in Mexico in 1980. The first autologous transplant in clinical risk was done in 1993. 3 years later, the first allogeneic transplant. And the first transplant for persons with multiple sclerosis was done 10 years ago in 2015. By 2023, we have done in clinical risk 1,500 transplants for persons with multiple sclerosis. Next slide, please. Very recently, we were granted this certificate of completion of the step 1 qualification in the FACT JC stepwise accreditation program, which is a joint program between the Foundation for the Accreditation of Cellular Therapy and the Joint Accreditation Committee of the International Society of Cell Therapy and the European Bone Marrow Transplantation Society, the JC. We have completed step 1, and we are in the process of obtaining the step 2 certificate of completion of this program, which is a way of qualifying the ability of our center doing stem cell transplants. Next slide, please. There are only 3 centers in Latin America which have been certified by the FACT, 1 in Brazil and 2 in Mexico, Dr. Gomez Almaguer in Monterrey, and us here in Puebla. These are the only 3 centers in Latin America which have this accreditation. Next slide, please. This is Ana Sureda, the president of the European Bone Marrow Transplantation Society. When he granted us this certificate of completion, the step 1 in Puebla some years ago, and Dr. Professor Daniel Curiel is also an authority of the Federation for the Accreditation of Cellular Therapy, and they granted us this certificate. Next slide, please. We are also heavily involved with the Center for International Blood and Marrow Transplant Research. We have been notifying of all the transplants that we do here in Puebla. And also we are part of the Be the Match network in order to be able to identify possible allogeneic donors for persons with hematological malignancies. Next slide, please. In the specific case of Puebla, these are our numbers. As I said, we started in 1993 doing transplants, and by March 3, 2025, we have done 2,225 transplants in our clinic, and 1,957 are autologous. This includes both hematological malignancies and autoimmune conditions. Next slide, please. As far as the indication of the transplant is concerned, I have to tell you that the reason number 1 to conduct allogeneic transplant here in clinical risk is acute leukemia, whereas the main reason to conduct transplants with autologous cells is multiple sclerosis. As you can see, the transplants done for other hematological conditioning, the hematological malignancies given autologous transplant are lower than those that we have conducted in persons with autoimmune conditions, mainly multiple sclerosis. Next slide, please. This chart here depicts the site from where patients have come to our premises to get the transplants. As you can see, most patients come from the United States. We have also patients coming from the United Kingdom, the Netherlands, Canada, Norway, Australia, Germany, and some other countries. making up a total of 1,700 patients with multiple sclerosis given this type of treatment in our facilities. This is the countries of origin of the HSCT Mexico participants between May 2015 and May 2024. As you can see, most patients are coming from the United States and also from Europe, but we have patients from different parts of the world. Next slide. We have also shown and published that the results are better in persons with multiple sclerosis if they get the transplant early in the course of their diseases. So if you are considering the transplant as a therapeutic option in multiple sclerosis, the best way to do it, the best time to do it is as soon as possible. Next slide. Disease-modifying drugs can slow down the progression of the disease, but only HSCT can halt it. This figure here refers to different type of treatments, interferons A and B, natalizumab, glatiramab, interferon, fingolimod, and some other drugs. But as I said, the best response rate to any of these drugs is around 50%, 50, whereas the response rate using hematopoietic stem cell transplantation is around 80%. Next slide, please. This is a picture depicts here the place in which these different types of treatments work in persons with multiple sclerosis. Rituximab, ocrelizumab, ofatumumab, natalizumab. But the most effective treatment is the hematopoietic stem cell transplantation because it shuts down the immune system and is endowed nowadays with the best response rate of all the treatments for persons with multiple sclerosis. Next slide, please. This picture is part of a paper that we just published. It refers to the response rate to several drugs. As I said, ocrelizumab and cladribine are endowed with a 50% response rate or less. Interferons are even lower, and as you can see here, most of the programs conducting hematopoietic stem cell transplantation for multiple sclerosis are endowed with a response rate of around 80%, such as ours and others ones such as those of Dr. Bort and Dr. Hammerschlag in Brazil and so on. So it is clear that the best response rate is for hematopoietic stem cell transplantation as compared to other drugs employed in the treatment of this condition. It is not only better, the response rate with transplant, but it is also cheaper. There are calculations that indicate that the long-term expenses of having a patient with one of the novel drugs, such as ocrelizumab, is substantially higher, the expenses, than the expenses of autologous hematopoietic stem cell transplantation. So the cost-benefit ratio is better for transplants. As I said, we have also shown and published, here is one publication, which indicates that the long-term results of autografting persons with multiple sclerosis are better in those not exposed to prior disease-modifying therapies. So the message is, if you are considering doing a transplant, do it as early as possible in the course of the disease because that is associated with a better response rate. Next slide. These are the response rates of persons given or not disease-modifying treatments. As you can see, the drop in the EDSS score after the transplant is better than the drop of the ECSS score in persons who have been given disease-modifying therapies. So again, the exposure of the patients to disease-modifying treatment is related to a delay in the practice of the HSCT, and as a result, a diminished response rate to the transplant. Again, these data support the fact that the sooner, the better the transplant in multiple sclerosis. Next slide, please. This is the success rate 12 months after the transplant in relapsing remitting multiple sclerosis. As you can see, the success rate is substantially better if persons have not been given disease-modified drugs as compared to persons which have been given disease-modifying drugs. Again, these data support that the sooner the transplant, the better are the results. Next slide, please. By splitting the doses of cyclophosphamide in 2 blocks apart, we have shown that the side effects are substantially diminished. This is the bone marrow toxicity, the renal toxicity, and the heart toxicity is substantially less employing our method, which employs 2 doses of cyclophosphamide separated by a 1-week period. So our method is gentle with both the kidneys and the heart. Next slide, please. The damage to the renal function is less pronounced, dividing the 4 doses of cyclophosphamide in 2 blocks apart. Next slide. As well as the cardiac toxicity, which has been shown to be diminished by splitting the total dose of cyclophosphamide in 2 blocks apart. These are salient features of our method. Whereas the cellular ablation, the damage to the immune system, is also improved by doing the delivery of the 2 blocks of cyclophosphamide in 2 different blocks apart, separated by 1 week. Next slide, please. This is the salient features of our program. The 2 initial doses of cyclophosphamide, 50 milligrams per kilo, are given in days -11 and -12, and then the 2 additional doses to make up a total of 4 doses and adding to a total amount of cyclophosphamide of 200 milligrams per kilo are separated by this 7-day period in which the patient is given filgrastim to improve the collection of the stem cells. By doing this separation of these 2 blocks apart, we have shown that the toxicity is less, whereas the results are the same as compared to other methods who employ 4 consecutive days of cyclophosphamide. We conducted transplant in day 0, and then at the end of the transplant, usually at around day +8, patient is given the Rituxan in a fixed dose of 1,000 milligrams, irrespective of the size of the patient. So this is the salient feature of the so-called now Mexican method to conduct hematopoietic stem cell transplantation in persons with multiple sclerosis. Next slide, please. Accordingly, we believe that this is a very safe procedure. We have been informed this morning that the paper dealing with 1,700 persons with multiple sclerosis analyzing the safety of the procedure has just been published in the journal Bone Marrow Transplantation, which is the journal with the highest impact factor of all the journals dealing with bone marrow transplantation. So our methods have been already published in this very prestigious journal. Next slide, please. Out of 1,796 patients treated since 2015, 4 fatalities have occurred, one of them related to the hematopoietic stem cell transplantation. This is a very low mortality rate, and it's interesting that no fatalities have been reported related to HSCT 5 years after the procedure. Next slide, please. We have shown data about the effectiveness of our method. The response rate is around 80%. Next slide, please. And we have employed it in relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis, primary progressive multiple sclerosis, and we can do the transplant independent of the progression or of the relapse activity of the patients. Next slide, please. We have published our results. These are the self-reported changes already published in clinical and experimental immunology. Changes in the expanded disability scale in patients with multiple sclerosis after autologous hematopoietic stem cell transplant. Next slide, please. These are waterfall plots. The lines going up indicate that the EDSS score has increased. The line remaining at 0 with no change remains that the EDSS score has remained stable after the transplant. And the lines that go down indicate that the EDSS score has dropped. So if you add the stabilization of the disease with the improvement of the disease, you end up with an 85% response rate in the specific case of relapsing remitting multiple sclerosis 12 months after the transplant. In primary progressive multiple sclerosis, the response rate is 80%, and the non-response rate is 20%. Next slide, please. Whereas in secondary progressive multiple sclerosis, the response rate is 79%, and the non-response rate is 21%. This indicates that our method works in all types of multiple sclerosis, making these findings more easy to analyze. In primary progressive multiple sclerosis, the response rate at 12 months improves at 18 months. The secondary progressive multiple sclerosis persons also improve their response rate, whereas the relapsing remitting multiple sclerosis persons also improve 18 months after the transplant. So this figure indicates that the response rate for all persons with different types of multiple sclerosis is around 80%. Next slide, please. Statistical differences were found between baseline quality of life and repeated measures at 3, 6, and 12 months after HSCT, including the mental and physical compounds. This is analysis of the quality of life, physical quality of life, baseline at 3 months later. And if you compare this graphically, this is a radar plot. The blue data are before the transplant, and the pink data are after the transplant. And as you can see, 1 year after the transplant, there is an improvement in chance in health, sexual function, health distress, cognitive function, social function, and so on. So the quality of life of the patients given HSCT also improves. Next slide, please. We have been very active presenting our data in different meetings. This presentation was done when we had grafted 1,300 persons in the meeting of the American Society of Hematology held in 2022. By now, as I said, we have now an experience of 1,700 persons with multiple sclerosis transplanted. Next slide, please. These pictures were taken when we did the transplant number 1,500 in patients with multiple sclerosis. This is the patient, and he came from the Netherlands. One of our patients is Sahira Ahmed Norris, who came to our premises in a wheelchair, and now is running marathons all over the world. This is in the Berlin Marathon. She has been in Japan and in some other countries, and it's a living proof that the transplant for persons with multiple sclerosis may produce spectacular responses, such as the one experienced by Sahira. Next slide, please. Now, there are some other methods to conduct a bone marrow transplant. One of them is the BEAM method, which is more aggressive, more myeloablative. And a comparison recently done between these two methods indicates that the results are about the same, but that the toxicity is substantially diminished with the Mexican method for the reasons that I already explained. There is no evidence of beam superiority compared with other protocols. And as I said, there is evidence of more toxicity related to the more aggressive protocols employed to treat persons with multiple sclerosis. Next slide, please. This is a study that we published in Clinical Transplantation, in which we analyzed the safety of the outpatient chemotherapy delivery and not transplant using refrigerated non-frozen grafts in persons with multiple sclerosis. Next slide, please. Less than 5% of patients develop neutropenic fever, and this is different from what is observed by using BEAM, in which up to 16% of patients do develop neutropenic fever. But we suggest the employ of face masks and neutropenic diet during the stages of maximal bone marrow depression. Next slide, please. We end up bringing to the hospital 4.2% of persons, and these are because of neutropenic fever, pneumothorax, dehydration, or nausea. Our hospitalization rate is very low. We are able to conduct the transplant fully on an outpatient basis in around 96% of patients. Next slide, please. Most patients, specifically 90%, can be grafted employing a single apheresis procedure. In a few proportion of patients, 2 or 3 procedures are needed, but this is very infrequent. Next slide, please. Around 90% of patients do not require transfusion of red blood cells nor platelets during the transplant, and accordingly, it is possible to fully accomplish the HSCT without any transfusion. Next slide, please. And it is clear that life after HSCT, once the patient leaves our premises, is easier. You don't need to stay in a bubble. We provide the patients with the do's and don'ts after the transplant, but they may resume their normal lives very early after the transplant procedure is done. Next slide, please. We suggest measures such as avoiding crowded places and a clean diet, and regular lab tests performed by a general practitioner, and revaccination are advised after HSCT, and we suggest to avoid infections after the procedure. Next slide. As a result of the changes that we have done in the methods to conduct hematopoietic stem cell transplantations, we were recently granted with this Distinguished Service Award both Dr. David Gomez Almaguer and myself, and this Center for International Blood and Marrow Transplant Research has distinguished us as persons having experience in making available hematopoietic stem cell transplantation to a larger number of individuals all over the world. Next slide, please. The Mayo Clinic also granted this Mayo Clinic Distinguished Alumni Award here in Mexico. Next slide, please. And also this honorary degree, Doctor Honoris Causa, was granted by the Universidad Autónoma de San Luis Potosí, which is the university in Mexico where I trained for my undergraduate studies. Next slide, please. Now, within 2 weeks from now, we will present our data in this 51st annual meeting of the European Society for Blood and Marrow Transplantation, which will be held in Florence. The data about the early mortality of our program, with experience in 1,700 patients, will be made as an oral presentation. We have also 4 poster sessions in which data of our program will be also presented, and there's also an e-poster. So we are very satisfied that our work is being recognized all over the world and will be presented to the medical community here in this meeting of the European Society of Bone Marrow Transplantation. I think I will stop here, and I will ask Dr. Olivares Gasca to take over the presentation of some features of the core, the place where the patients are kept during the transplant. Juan Carlos?
Perfect. Thank you, doctor. So during your treatment, you will be in a building that it is only for patients that are receiving HSCT. So in that building, we have adapt and furnish rooms for MS patients. So every suite contains 2 bedrooms, air conditioner, 2 elevators, and it is only occupied by the Clínica Ruiz staff and patients. So in that place, patients has Wi-Fi connection, restaurant, roof garden, a gym, business center. So the idea is that the patient is as comfortable as possible during the treatment. So as you will be fully outpatient, you can enjoy all of these features during the treatment. Also, we will provide the food during the treatment, and it is the menus are recommended by the doctors, also the portion. So everything will be take care for you to only be focused on your recovery from the treatment. Also, the treatment, we did a comprehensive package for patients that includes the laboratory testing, medication, blood bank, the conduction of the treatment by Dr. Ruiz and Dr. Gomez, the surgeon and anesthesiologist for the catheter placement, the hospital for the catheter placement, chemotherapies, spirometry that it is done prior to the first doses of chemo, AKG, cardiologist consultation, neurologist consultation, transportation. So the idea is that you just only need to arrive to any airport in Mexico, and we'll pick you up, do the treatment, and bring you back to the airport so you can return back home with everything solved for you. So now we will show you this video about the facilities that we have in the core building. So everything is fully adapted for the patients. So we have 2 elevators that fits perfectly a wheelchair. And these are the rooms, the suites that we were talking about. Every suite has 2 bedrooms, one for the patient and the other one for the caregiver. And this is the other bedroom. And the bathroom that it is fully equipped for patients that requires more assistance. A small kitchen that you will not require to use it for cook, as the food will be provided by the restaurant that it is downstairs. That is going to be shown later. This is the rooftop where most of the patients like to enjoy sunny days here in Mexico. During the treatment, you can be outside and enjoy the views from that. We have a smoking area for the caregivers. And then this is the gym that some patients use during the treatment, also the caregivers. So it's very helpful that during the treatment patients stay active. So a lot of patients use the gym during that time. So in the same building, we have 6 consultation rooms where we see the patients during neutropenia and other evaluations. So this is one of the consultation rooms that we use in there. So the idea is to do the things easier. There is a nurse 24/7 in the building. So if anything is needed, it is not a hospital, but we can address any complication there. A little lobby area, and the map that is famous. All the patients put a pin over the place where they come from, so we're collecting a big amount of pins in there. This is the restaurant that provides food to the patients. You can eat downstairs, or we have room service for the patients during neutropenia. So all the patients can eat in the room, or also in the rooftop if they prefer to do so. And now we will show you this video that is the facilities in Clínica Ruiz. In this place, we do all the chemotherapy sessions and the harvesting of the stem cells. So this is the chemotherapy room, where we conduct all the administrations of cyclophosphamide and also the rituximab at the end of the treatment. And this is the apheresis room. In this place, we do the collection and the harvesting of the stem cells. So we have 3 apheresis machines that make us one of the biggest apheresis centers in the country. And also here is the Dr. Ruiz's office, where he's just at this precise minute. Perfect. So thank you so much for your attention now.